I'll just invite the last speaker, Dr. LAV KOCHGAWAY, who unfortunately got delayed because of delay in his flight. He'll be talking about carrying on from where Dr. Jagatram had left on pediatric cataract. He'll be talking on pediatric traumatic cataract, different scenarios. Dr. LAV KOCHGAWAY also from Calcutta has been doing some wonderful work in pediatric cataract and pediatric ophthalmology. And it's definitely a pleasure to listen to Dr. LAV KOCHGAWAY.
Thank you, Dr. Rohit. And because it was Patna, I touched down at 4:05 and was here by 4:30. So, the topic on which I would be speaking is traumatic cataract. And just a brief one slide, and after that we'll go to the videos. The different scenarios what we get in children, especially most of the traumatic cataract what we get is children, and can be either a blunt or penetrating trauma. Timing of surgery is very important because most of the open globes, the incidence occurs in semi-urban or rural areas, and by the time they reach the tertiary eye care facility or where general anesthesia facility is available, it may be a bit late, so it has to be operated as soon as they report. And after taking a fitness for general anesthesia. So we'll go through some of the scenarios what we face, and this was a penetrating trauma which presented late. So the primary corneal wound was almost self-sealed, so we decided to go ahead with only cataract surgery. And as you can see, there was an opening in the anterior capsule, pre-existing opening, so capsular access was delayed after, and was done after the cortical aspiration. And that was done using a cutter, because with a high-speed cutter, you get a very smooth margin. So this is a good substitute to manual capsular access in difficult cases. And a decent size opening is important because we want to place the IOL in the bag. And a 3-piece IOL here in this case has been placed in the bag. And wherever possible, and in young children, especially if they are less than 7 years of age, it is very important to do a posterior capsular access also. And with the manipulation, the corneal wound opened up, so a single suture was applied to the corneal wound. Main port is always sutured in young children, and a posterior capsular access again using a cutter. So this is how this case ended. Next comes a blunt trauma which led to a cataract and a fibrosed anterior capsule. And once you have a fibrosed anterior capsule, the most important step becomes the anterior capsular access, because again, in children, we want the lens to be placed in the bag, so we have to have a decent size round opening. So when first manual capsular access was attempted, and as soon as you hit the fibrosed area, after which proceeding manually is difficult, which was tried using a forceps also. But as you can see, it was not possible after this, so a cutter was used to make a smooth opening in the fibrosed area of the capsule. Slowly, and the trick is for thick membranes, the trick is a slightly lower cut rate and a higher vacuum. If the cut rate is very high, then cutting membranes becomes difficult with the cutter. And we kept on trimming till we got a decent size anterior capsular opening. After which cortical aspiration is done. And now you have a clear view of the size of the anterior axis, which is almost 5 or 5.5 millimeter, and the lens has been placed in the bag. And then you go behind and do a posterior capsular access as usual. For many years now, I've given up manual posterior capsular access, and I've been doing it only with a cutter. and gives a very good result. Another scenario what you can get is intraocular foreign body along with cataract. So here, once we started cortical aspiration, what we saw was a foreign body, and it is very important to remove it to prevent future inflammation and infection in the eye. So that was removed. And this is slightly different from what we had done earlier. A Utrata forceps, the Vanna scissor was used to cut the anterior capsule, and the rest of the capsulorhexis was completed manually. And the end of it, you have a bag, though one side the capsulorhexis is deficient, but still we are able to place the lens in the bag. And the problem, long-term problem that can happen in this case was that one side, if the bag starts contracting, then the IOL may get decentered. This is another case in which presented with a blunt trauma, and what you see is a fibrosed anterior capsule and a small pupil which was stretched manually. Stretching of the pupil can be either in these cases, especially when there is a posterior synechia and irregular pupil, hooks work better than the Malugin ring or any other device. So a small opening was made in the anterior capsule, after which first the cortical matter was removed, and now you have to trim the rhexis margin. So most important, what you have seen in most of these videos is that we have to be very familiar with use of cutter, and especially those of us who are operating pediatric cataract, they should be very, very comfortable with the cutter because there are various scenarios in which it has to be used. And in this case, even the posterior capsule is fibrosed, so once you are cutting, then you see how the visual axis gets cleaned up, and a slightly larger posterior capsulorhexis is made, and this is the final outcome. Next comes what sir had shown, posterior lenticonus. This is a variant of posterior lenticonus. As you can see through the total cataract, the posterior capsule is deficient, and you can see the thick margins of the posterior capsule. So most important, don't do any hydro procedure in these cases when you are suspecting a pre-existing PC defect. And once this cortical aspiration has been done, and this is an error, you should not have come out of the eye suddenly. It should have been, the viscoelastic should have been pushed, and then I should have come out. And due to that, once you are trying to dial the lens, it doesn't go in the bag because of the vitreous in the bag. So vitrectomy was done. And then after that, once you dial the lens, and it goes comfortably in the bag. So this is one of the errors we should avoid. When there is a pre-existing PC defect, don't decompress the eye suddenly. This is traumatic lens subluxation. Again, good part about these subluxations are that these are not progressive. So if you are able to achieve with just a CTR, it may stay there without progressing further. And if not, if the lens with the CTR is still decentered, then we should apply a scleral fixation device. So, and another, what you see in this here, vitreous is coming from the loose portion. So dictum is, once you have vitreous in the anterior chamber, first deal with the vitreous and then go back to cortical aspiration. Because if you are doing cortical aspiration with the vitreous in the anterior chamber, then that will cause vitreous traction and some retinal complications are possible. After the cortical aspiration, CTR is implanted in the bag, and it can be done either with the main port or side port, whatever you are comfortable with. And after that, the CTR implantation, what we see is that the bag is fairly well centered. Let us see after the IOL implantation. And even the haptic in that area helps in centering the IOL. The vitreous is cleared from the zonular weakness side. Main port is sutured. And this is the final outcome of the case. So thank you so much. Thank you for the opportunity.
Thank you, Dr. Love, for excellent videos. You have shown these fibrosed capsule, which is very common in these. And many of these children, irrespective of the age, they may need primary posterior capsulotomy, as you have done.
Yes.
And I think centration of IOL is extremely important, and many of the times it may need 3-piece IOL. But many times you can put
a single piece also.
Yeah. So it was excellent presentation.
Thank you, sir. B scan definitely, if it is, if you are not able to visualize. UBM, we should do when we are suspecting, suppose a pre-existing PC defect or anything, but it depends whether you have a facility in your center or not. In my case, I don't do UBM routinely. If you are suspecting a PC defect. Otherwise, also pediatric cataract, you don't need hydro. Actually, you don't need hydro.
Any other question or comment?
See, if you are, for capsule, I use around 1500, 1200 to 1500 cut rate and vacuum of 200 to 300. But when you are doing vitrectomy, it has to be the highest cut rate for that machine. And vacuum of maybe 200. Yeah, that is what I showed in many of the cases. No? It again depends on surgery. See, manual is very firm rhexis. Nothing can replace a manual anterior capsule rhexis. But if you have a 23 or 25 gauge cutter and in normal capsule, you can even go for a higher cut rate. You get a very smooth round edge. If surgeons are comfortable with that, no harm in doing that.
Thank you. I think